Good morning, and thank you for joining us today. My name is Ann Brazo. If you do not know me, I'm the CEO and founder of MPN Advocacy and Education International. I've been in the MPN space for many years, since 2005, when the JAK2 gene mutation was discovered. And boy, if any of you were diagnosed at that time or working in this field, you will know that a tremendous amount has happened since then. We have 2 drugs on the market specifically for MPNs. We have many in the pipeline, and possibly a couple or 3 may be commercialized in 2021. We're hopeful. And so, you know that we host educational programs throughout the year, typically in person, but because of the pandemic, have been hosting programs online like these. We started conversations with the specialists, which this will be another one of those in our series of these conversations. We decided to focus on the 3 major MPNs. Today, we are strictly focused on MF. We have 2 fantastic speakers and colleagues, Dr. Ellen Ritchie and Dr. Raajit Rampal. We will begin with Dr. Ritchie. And but before we start, I would like to thank all of our sponsors and all of our industry partners who have been so great with us and making us able to host these programs. Just as a side note, if you have questions, you can send those to me via just writing them down. In the right-hand corner, there's a side panel on your screen, and you can send questions from that area. And I will get those. We'll try to get to as many as possible. Both physicians will speak for 15 minutes, and then the rest of the time is for you and your questions. Okay, Dr. Rampal is with us from Memorial Sloan Kettering. I do want to say this for anybody on this webinar that is a Vietnam vet. Dr. Rampal has partnered with us years ago and has been our person that we go to talk about the issues with Vietnam veterans who were exposed to Agent Orange that have an MPN. We will be putting new stuff on our website with his assistance to help you to hopefully get some benefits if you have an MPN and are a Vietnam vet. Without further ado, Dr. Rampal has worked effortlessly in the MPN space and has a lot to share with you about the treatment for myelofibrosis and current approaches and new concepts. So Dr. Rampal.
Okay, great. Thank you, Ann. I always look forward to these events, and just like everything else in our current environment, I wish we could all be together to talk. On the other hand, the technology gives us the opportunity to talk to a lot of people at once, and so I think that that is the upside of all of this. Today, I'm really just going to give you a really high-level overview of where we are and where I think we can and should go, and then obviously the emphasis today is really on your questions, and I hope we can address a lot of those. These are just my disclosures for my relationships for consulting and research. So, when we think about myelofibrosis, the question sort of is, what happens? The most common thing that occurs when I meet a patient who's newly diagnosed is, what's going to happen to me and when? And the answer is not one that we can make with ease, because we really can't predict the future, but we can sort of approximate what the possibilities are based on what we know about a patient and what we know about their genetics. And in general, what are the things that we worry about, or what are the things that happen with myelofibrosis? It's important to recognize that we know that there are a proportion of patients who will be diagnosed and they will do fine for 10 to 15 years. And we can understand some of this from their genetics based on their mutations at baseline. But we know that there's other patients who, within a year or two of meeting them, are going to be on the verge of leukemia or something else. And I think one of our major challenges that I'm going to talk about at the very end is trying to figure out who those patients are. In other words, myelofibrosis patients are not one pot, rather they are sort of like marbles in a jar. Everybody's a little bit unique and different, and our job and our task, I think, as we're understanding it now, is to figure out who's going to do what, which marbles are going to go into which jar. That's one of the major areas of emphasis currently. So overall, in thinking about myelofibrosis, the things that can occur and that we worry about and that we want to try to treat and ultimately, I hope, prevent, are that people can have symptoms. So constitutional symptoms, and constitutional symptoms mean things like fevers and night sweats and unexpected weight loss, muscle aches, fatigue. All of these things are really, really important things for a treating physician to recognize and to be cognizant of. Things like fatigue. Fatigue is amongst the most common symptoms in patients with MPN. We have to recognize those things and keep track of them, because symptoms progressing are a reason to treat somebody, aside from just the blood numbers. We worry about things like what we call progressive organomegaly, meaning that the liver and the spleen principally become enlarged over time, or can become enlarged over time. And really, we think part of that is that the cells that are at the root of myelofibrosis are able to circulate, and they can take root in the spleen and the liver. And part of the reason that might be is that when you are a fetus and in the development stage, you actually make most of your blood in your liver, to some degree in the spleen. And so those organs still have some residual ability to create blood, which the malignant myelofibrosis cells take advantage of, as do normal cells to some degree. That is really a manifestation of the disease essentially growing elsewhere, but it can actually occur in other places that are odd, like the lungs and sometimes in the bones. Occasionally you'll see that in the skin. Not a common thing, but it can occur. We worry about patients' blood counts. Many patients will have progressed from a previous disease like polycythemia or essential thrombocythemia, where they're making too many cells, too many red blood cells, too many platelets. And what can happen over time is that once the disease progresses into myelofibrosis, people actually go from getting phlebotomy, for example, for polycythemia, to actually needing blood transfusions. So patients' blood counts can drop. They can become anemic, they can become thrombocytopenic, meaning that they have low platelets. And the white count, more often than not, is elevated, but it can be lower than normal in some cases. So we worry about that, because if somebody is anemic, they can have symptoms from that. They may need blood transfusions. If somebody has low platelets, they may become at higher risk of bleeding. They may also need platelet transfusions, all of which we know are associated with the disease having a more aggressive course. We worry about the disease turning into leukemia. I think that is probably the most challenging thing we deal with in myelofibrosis. Certainly not the most common, only occurs in about 20% of patients, but it is incredibly challenging to treat, because the things that we use to treat leukemia historically have not worked well in patients who have myelofibrosis that transitions to leukemia. So these are kind of the things that we think about when we're thinking about what are the things that can happen to a patient, and how do we think about treating them, is the next question. And the answer is, as I stated earlier, we don't think about patients as sort of a monolithic entity. We think about patients as individuals, and so the approach to treating patients is individually. The treatments that we use really at this point depend on what the problem is. In patients who have an enlarged spleen that is symptomatic, or who have debilitating symptoms, the constitutional symptoms I talked about a moment ago, we have two really good frontline drugs. We have ruxolitinib and we have fedratinib, and both of those are what are called JAK inhibitors, and they are highly effective at shrinking the spleen and the liver, actually, and reducing patient symptom burden. They do a really good job of that. But in patients with anemia, we've historically used a number of different types of drugs. We have drugs called erythropoietin stimulating agents. These are injections such as darbepoetin, an erythropoietin that we give people every week or every 2 weeks. That can work in about a third of patients. There are other drugs, ancient drugs like thalidomide, and lenalidomide, which we think still have really good potential in myelofibrosis. Things like danazol and steroids. All of these things work in about 30% of patients with anemia. For people who have early disease, there is some literature to suggest that interferon, which we know works in polycythemia and essential thrombocythemia, may work, but it seems to really only work early on in the disease when the spleen isn't massively enlarged. For things like what we call extramedullary hematopoiesis, which is really where the cells from the myelofibrosis have taken root elsewhere in the body, the spleen and liver, but more typically elsewhere, like in the bones or in the lungs, we can use radiation to treat that sometimes. And for people whose disease is progressing into the leukemic phase, we use drugs that are called hypomethylating agents. And these are drugs such as azacitidine and decitabine, which have now been fairly well studied in more advanced myelofibrosis and certainly do seem to have some benefit for patients. But ultimately, the goal is to try to improve patient survival. And right now, the only way to really do that is with a stem cell transplant. There is data from the trials of ruxolitinib that does seem to indicate that there is an improvement in survival when several different studies are put together. But that really, I think, is our major challenge at the moment. Now, as I mentioned, ruxolitinib and fedratinib are highly effective drugs to shrink the spleen and to relieve symptoms. They don't change the biology of the disease. In other words, they aren't what we call disease-modifying drugs. They treat the disease, they don't cure the disease. And we have to recognize that as a limitation. But the other limitation is that patients may progress even if they're doing well on a drug like ruxolitinib or fedratinib. And we've known this for some time, that if you look at time from the start of treatment, the number of patients who are staying on treatment diminishes, partly because some go to transplant, but partly because people start to become resistant to their JAK inhibitor, which happens for a variety of reasons. Not in all patients, but it certainly does seem to happen in some genetic subtypes of patients. And so, again, the challenge is that, yes, the JAK inhibitors have done a great deal of good. They revolutionized the treatment of this disease, let's be honest. We have to do better, and that means building on the success of ruxolitinib. So how do we do that? Well, I'm not going to go through all of this because we don't have the time, but I'm going to give you a high-level overview of what's going on really briefly. And what I think one of the main things I want you to take away from this is this is an amazing time in myelofibrosis. I think that we have so many different drugs and agents in development for this disease. It's incredible. I'm at the point where I'm having to turn down trials. Whereas when I was at the start of my career in MPNs, which was not that long ago in 2012 or 2013, we were really looking for novel trials with new agents. There weren't that many of them back then. And so we're to the point where I almost think we have more trials than we do patients. That's a good thing. Don't get me wrong about that. What I want to do is just break this down to you in a couple of different ways. The first is that when we talk about trials go through a number of different phases. It's a strange thing that in the current time that we're living in, I think the general non-medical public has become very well versed in clinical trials nomenclature, because we all tune into the news, or we were in the fall, waiting to hear about the phase 3 results of the Moderna or the Pfizer vaccine, which obviously are life-changing for every single human on this planet. But we've become versed in those terms. What are phased trials? What does that mean? So really basically, when we talk about a phase 1 trial, we're talking about drugs that have shown some biological efficacy, either in animal models like mice, or in cells in the lab. And so we put them into patients with the idea that in a phase 1 trial, we're going to figure out what's the safest dose that we can give, because you're taking a drug that's only really been studied in the lab and giving it to humans for the first time, trying to figure out, is there a safe dose, or what is that safe dose? If we find a safe dose, we go into a phase 2 study. And in a phase 2 study, the goal is to see, does it have activity against the disease? If it does have activity against the disease, then a decision can be made to put a drug into what's called a phase 3 trial. Now, phase 3 trial essentially tests whether that new drug is equivalent to the current standard of care or is better than the current standard of care. So for a drug to get to the phase 3 trial, or to a phase 3 trial, it has to have shown that there is some reasonable activity and that there is reasonable safety. Now, in that vein, there are now at least 4 different drugs that are entering phase 3 trials in myelofibrosis, and this is not meant to be an exhaustive list by any stretch of the imagination. But there are, briefly talking about these, there's the trials that are going into phase 3 I've listed here at the top. So one is CPI 610, which is what's called a BET inhibitor. We can certainly talk about what that is and how it functions. And that drug, the mechanism behind it has been well studied by our group at MSK. And the drug has been tested both in frontline in patients who have not been previously treated in combination with ruxolitinib, as well as being given as an add-on to people who are on ruxolitinib, and also as a single agent. And in all of those studies, the drug has shown that it is able to reduce the size of the spleen, that it is able to reduce symptoms, and that it may actually improve a patient's anemia. So now that is being tested in a phase 3 trial where patients will get randomized to ruxolitinib or to ruxolitinib plus CPI 610. So that will be a definitive trial, and if it's positive, we hope that that will lead to approval of the drug. Another drug class is called navitoclax, which is what's called a BCL2 inhibitor, BCLX inhibitor. And BCL2, BCLX, without getting too far into biology, are just sort of anti-death signals. And so this is a way to try to tell the malignant cells that it is time to self-destruct. Again, this is the studies that have been done so far with this drug have shown that in combination with ruxolitinib, it is able to shrink patients' spleens and improve their symptom burdens. Another drug is in a class of drugs called a PI3 kinase inhibitor, and this is a drug, INCB, with lots of numbers, but also now called paraciclib. And this is also going into phase 3 trials for patients who have both not ever had any treatment, as well as patients who have had prior treatment. And then another class of drugs called MDM2 inhibitors, which are another mechanism by which you can try to tell a cell to auto-destruct. And this is being tested in combination with ruxolitinib in patients who have had prior exposure to a JAK inhibitor. So these are all in phase 3 trials. And again, the importance of that is if the signal is positive, these drugs could become FDA approved and would give us a whole slew of new drugs to treat this disease. I mean, this is an amazing thing. Other drugs to just sort of briefly update you on. There are other JAK inhibitors that have already been studied extensively and are being studied further. One is momelotinib. And this particular JAK inhibitor seems to show a signal for improving patients' hemoglobins, which is really the opposite of what we have with our current JAK inhibitors, ruxolitinib and fedratinib. Further data is needed, but I think that's a really promising signal, and it might really be a drug that could find a home for patients who have anemia as one of their major symptomatic problems. Another issue we run into frequently are patients with really low blood counts, and we mean platelets under 50,000, for which no JAK inhibitor is FDA approved. Both Rux and fedratinib are approved for patients with more than 50,000 platelets, but pacritinib is actually being studied in patients with under 50,000 platelets. And that, if that gets approval, and it is currently in phase 3 trials, could lead to treatments for patients for whom we actually have no standard of care currently, which would be a welcome development. We are combining JAK inhibitor with old friends, old drugs that have been used for both MPN and other indications. So we talked about hypomethylating agents. So we've used ruxolitinib for myelofibrosis as well as more advanced disease that has essentially turned into AML. Interferon, which is of course well known in this field, is being combined with ruxolitinib, both in myelofibrosis and in ETPV, and old drugs like thalidomide, which used to be used in this disease before JAK inhibitors, and certainly we're seeing that in combination with ruxolitinib, patients with low platelets seem to be benefiting and having an increase in their platelet counts, even on JAK inhibitors. So we think that's promising. There are drugs that don't even work by JAK inhibitors and are being studied by themselves without combination. These are drugs that, like the anti-fibrotic agent PRM-151, or something called a telomerase inhibitor known as imetelstat, which is being studied in a phase 3 trial, as well as a drug called SL-401, which is also known as tigrascafus. That drug is actually FDA approved for a disease called blastic plasmacytoid dendritic cell neoplasm, but it's not approved for myelofibrosis. It is being studied for myelofibrosis. And there are novel drugs that are being employed in these diseases, like something called a TGF-beta inhibitor, and this is a trial from the MPN Research Consortium, as well as a targeted drug against a gene called IDH2, which is found in about 10% of patients with myelofibrosis, but 20 to 25% of patients in myelofibrosis or MPN that's transformed to leukemia. It's FDA approved actually to treat leukemia, but we're testing it in combination with ruxolitinib. And the other drug that looks like had fallen off of here was an LSD1 inhibitor that is also being studied and has shown preliminary efficacy in terms of symptom burden and spleen size reduction. So I think the take-home message here is really not to focus so much on these drugs and their names, but to understand that we have an incredible number of drugs under investigation, and we have a number of drugs, these 4 up here of novel agents and the JAK inhibitor pacritinib, that are in phase 3 trials. I'm sorry, both of the JAK inhibitors. So we have a number of drugs that are in definitive trials now that, if they're successful, will lead hopefully to FDA approval. So the last thing I will leave you with before we go to questions is coming back to this schema. And as I talked about in the beginning, we worry about these different possibilities that can happen to MPN patients, and we are working on drugs to help them, right? We've talked about JAK inhibitors to treat symptoms or organomegaly. We've talked about some of the drugs like pacritinib for people who have low blood counts. So we tend to intervene and treat patients when they start to develop problems. But I would argue to you that it's come time for our paradigm to start to change in MPN. I think that we really need to start to think about intervening before patients have problems. It's a little bit simplistic to compare this to other cancers like breast cancer, but when someone's diagnosed with breast cancer, we don't say to them, come back when your disease is stage 4 and widely, all over the place. We intervene at the time of diagnosis. We haven't done that here, really principally for 2 reasons. Number one, as I said earlier, there are a proportion of patients who we know are going to do fine for 10 to 15 years. They don't need the intervention, and maybe intervening in those patients is really going to do them more harm than good. So the problem there is we have to begin to figure out who are the patients who are at most risk of progressing, and that includes the myelofibrosis patients, but also the ET and PV patients who may progress to myelofibrosis. Most patients will not progress to myelofibrosis, but some will, and those patients are going to have a more difficult time. So I think our task is really to start to identify those MPN patients who are at the highest risk of progression and think about intervening early on to prevent these problems, rather than trying to catch up at the end when people have already developed more severe disease. That is, I think, how we need to change our entire paradigm of treating myelofibrosis. The second issue that has prevented that is the availability of drugs that are biologically effective. And again, I think that we are in a maybe golden age where we have now many drugs that have clear biologic activity. Whether or not they get approved is a little bit of a different discussion, because how drugs get approved doesn't necessarily tell you whether or not they're actually biologically effective. But we are in a position now where we have a much better understanding of the biology of the disease and much better drugs to try to intervene. And so I think if we can work towards identifying the patients who are at highest risk, we may be able to intervene with some of our newer drugs and change the natural history of the disease, which is what we all want. Curing the disease would be the highest goal, but if this turns into a chronically treatable condition by intervening early, that would, I think, be a much better position than we are in now. And I think it's important for everyone to recognize, some of you may be aware of this, some of you may be not, that this is a topic that has been under discussion for the last several years, and it's really been led by the MPN Research Foundation. They have taken the bold step of convening experts to talk about the idea that we want to identify markers of progression, things that tell us a patient is going to progress, and then to figure out a way to intervene early on to prevent that from happening. And so I'm privileged to be a part of this initiative, and I'd like to share with you that earlier this year, we actually had a meeting convening, I think, many of the experts around the world to discuss this issue and actually to talk about research proposals and actually to fund those research proposals. So this has gone from a drawing board idea to something that is being acted upon now. And again, I think this is the necessary change to change the paradigm of myelofibrosis. So with that, I will end my formal presentation, and I'm happy to take any questions.
Hi, Raajit. That was fantastic. And I have to say, you know, having been around since 2005, when there were phlebotomies, transfusions, hydroxyurea, and I think that was about it. Maybe a couple other drugs that were for other symptoms or other diseases. So for me, having been around for so long, it is absolutely wonderful and a miracle almost that there are just so many drugs in the pipeline. I think the initiative, the progression initiative, is long overdue. And I loved what you said, you know, this whole subject of, do we treat at diagnosis time if there are no symptoms, or, you know, or the person is not symptomatic, or do we wait? And boy, that is a big question. And we talk to patients quite frequently, and many say, well, I'm not taking anything right now, but, you know, should I be? And so I'm really happy that you're looking at this question and determining, you know, if the landscape should change and how that would look. So we have a lot of questions, and I'm glad you went over the different the different inhibitors, not JAK inhibitors, but the other inhibitors. And so how are they different from JAK inhibitors?
You mean the new drugs or the new JAK inhibitors?
Well, the other, like, I'm thinking BCR-ABL, but I could be wrong. I mean, that, you know, or the IDH2, you know, how are those different?
Yeah, so I guess the way to answer that question is that everything starts with the JAK pathway. That's what is founds the disease. But the thing is, other things happen. We know that once that pathway gets activated, other pathways get activated that the cancer cells use or that they need to survive. So I talked about the BET inhibitors. We know that what the BET proteins do is they are part of the mechanism that allows the MPN cells to create inflammation and proliferate. And so it's another way, it's a way of targeting things that we know the cancer cell needs to survive. So it's helpful to think of these things as a cascade. If it starts as JAK2, the JAK2 activates 10 things, which activate 10 more things, which activate 10 more things. Some of those things are vital for the cancer cell to survive. Other things are just sort of bystanders, we think. And so a lot of the drugs that I've talked about are things that are sort of in that cascade, which we think the cells need to survive. And so by shutting off those pathways with the JAK inhibitor, we think we can sort of approach it from two different mechanisms. I think like the best paradigm that comes to mind is that of HIV. You know, way back in the 1980s, all there was something called AZT, which did something for a few months, but obviously patients died back then. And then they figured out that targeting multiple different things that the HIV virus needed to survive was the way to put the disease into sort of a low level and allow people to survive. And now that's the same principle I think that's being adopted in cancer. It has been for many years now. And that's sort of how I think about this.
So the big question is always, what criteria must be met to change the diagnosis from PV to MF?
Yeah, so there's a couple of things. The criteria that we use to make these diagnoses are World Health Organization criteria, WHO criteria. And the last version of that was from 2016. But the principal things are that in general, the bone marrow examination is really what tells you what's going on. And in the bone marrow of a patient with PV and MF look most often distinct. There are cases where it's a little bit ambiguous, but we look at the bone marrow, and depending on the shape of the cells and the amount of fibrosis, that helps make the diagnosis, as well as the presence of an enlarged spleen. And then markers from the blood, like an LDH, which is a marker of cell turnover. If that's elevated, that's one of the criteria, and often the presence of anemia.
Okay, so how does one know, who has MF when it has converted to leukemia or AML?
You know, in some people, as with everything with this disease, it's not the same for everybody. And some people become very symptomatic. Their blood counts go down, their red blood count goes down, their spleen gets markedly enlarged, they feel very sick. And in other people, it's more subtle. So the way we make the diagnosis is really from the blood and the bone marrow. And if the blasts in the blood have gone more than 20%, that's the definition of leukemia. You have to be careful because in myelofibrosis, blast count blasts are pretty normal in myelofibrosis patients, but they can fluctuate wildly. So if they're elevated on one reading, it doesn't mean they're going to stay that way. But it's usually over 20%.
Okay, we'll have one more question. We're going to ask all of these questions eventually, but we'll ask one more of you. And then we'll hear from Ellen, Dr. Ritchie, and then we'll ask both of you the remainder of these questions, and there are many. So what is the difference between MF and secondary MF?
So secondary MF is that diagnosis depends on the patient having had a prior MPN diagnosis, principally a patient who's had essential thrombocythemia or had polycythemia that progressed into myelofibrosis. We would term that secondary MF, whereas somebody who was just diagnosed with MF and has no history of ET or PV is called primary myelofibrosis. The trick, of course, there is that people may have had something like ET for several years and not known it, and they come to attention when they have symptoms of myelofibrosis. So it's not always cut and dry, but often is.
All right, thank you. And stay with us. We're just going to go to Dr. Ritchie's presentation and then ask questions, and we'll have the rest of the time just for questions. So thank you, Dr. Rampal. Dr. Ritchie is at Weill Cornell Presbyterian Hospital, and we are New York Presbyterian, sorry. And Dr. Ritchie's done extensive work in MF, and I particularly always call on her when we want to hear about some cardiac issues. But today she's going to talk about new agents and integrative therapies for myelofibrosis. So please sit in your seats and listen up, because these two have some great information for us. Thank you, Dr. Ritchie. And can you please turn your camera on? Thank you.
Hello, how are you?
There you are. Thank you.
I'm Dr. Ritchie from Weill Cornell, and I tried to guess what Dr. Rampal was going to talk about and try and do something a little bit different, which I think I'm going to be able to do, which is excellent. So I want to talk to you a little bit about myelofibrosis, just briefly mention some of the new agents that Dr. Rampal talked about, and talk about what happens if you're on drugs for myelofibrosis, but you still have symptoms and are not feeling well. Are there other things that you might be able to do that we have some evidence for that could improve your outcome? So, you know, we're lucky to have had ruxolitinib in our armamentarium, which is really the only drug that we've had that's been approved to treat myelofibrosis for many years. As Dr. Rampal said, symptomatically, we add other drugs or we change drugs, but in general, we use ruxolitinib. And unfortunately, you know, as he said earlier, you know, when we look at the 5-year update of the COMFORT-1 trial, you know, the duration of a spleen size reduction is not forever, you know, a median duration of 168 weeks, which is just over 3 years. So that we don't have, you know, other agents. Really, we have fedratinib now, but we have not had approved agents really to go forward and treat patients when the JAK inhibitors stop working optimally. So the overall survival analysis of the COMFORT-1 study, you know, really looked at all patients who died during the study or long-term follow-up. And there really was not an improvement in overall survival in patients who were treated with ruxolitinib versus placebo. That might have been in part because of a crossover that occurred in this trial. There have been many, many studies looking at ruxolitinib, you know, if you combine studies or if you really torture the data, that you're able to see a small benefit in overall survival. But in general, you know, the treatment with ruxolitinib is mainly a palliative treatment, as are many of the other treatments that we use for myelofibrosis. There are 5 new exciting agents that were discussed at ASH, and just as Dr. Rampal has told us, there are agents that are, you know, imminently possibly up for approval to treat myelofibrosis, which is amazing. We've never had so many agents at one time. At ASH, I was particularly interested in the IMG 7289, which is an LSD1 inhibitor, navitoclax, which is a BCL2 family inhibitor, imetelstat, which is a telomerase inhibitor, momelotinib, which is a JAK1, JAK2, and a hepcidin inhibitor, and CPI 6110, which is a BET inhibitor. Phase 3 trials are ongoing with navitoclax, imetelstat, and CPI 610, as with momelotinib. And these are all drugs that might be available through FDA approval to treat myelofibrosis in the next year or two. It's really exciting to have all these agents, and that may improve symptoms and outcome in our myelofibrosis patients. So, you know, the issue is, what if you're taking medications and they don't fully do the job, or they're not really improving your symptoms, or they're not really improving your quality of life? And I think that this is true for a lot of our MPN patients, and many MPN patients pursue integrative medicine strategies to try and improve their outcome. And this is not only true in patients who have myeloproliferative diseases, but in many patients who have chronic diseases, for example, chronic rheumatologic diseases, or other chronic cancers, where they're looking for something else to help manage their symptoms. And there's an interesting study that was, which was published in the fall of 2020, you know, which is called the SIM study, which is really a survey of, an online survey of MPN patients on what strategies that they used from integrative medicine to manage their symptoms, and looking at those strategies and the relationship to the MPN SAF TSS score, to measurement of depression, which is called the PQH, and fatigue, called the BFI, and a single question about quality of life. And there were 858 participants, and of those, 188 of them had myelofibrosis. And interestingly, most of the patients, are 3-to-1 ratio of females to males who participated in this study. And measures were compared by integrative medicine participation and adjusted for alcohol and tobacco use, BMI, diet and an MPN diagnosis. So I'm going to talk a little bit about these results because I think they're actually quite interesting for the MPN patients. The most commonly used therapies amongst MPN patients were aerobic activity, massage, yoga, nutritional supplements, and strength training. And 44% of patients in the study actually used supplements in the prior 6 months to enrolling, and undisclosed this to their physicians in 20.6% of cases. So there are many patients out there who've been using supplements and not discussing it with their physicians. And with these therapies, there are some sort of interesting results, which we'll look at in the next slide. I think it's really quite interesting that patients don't like to discuss their use of supplements. And this is really important, particularly if physicians are treating you with medications for your myelofibrosis or for your other ailments, and that these supplements might actually interact. So as I said, we've talked about this, how many different therapies were used, and I need the next slide. So let's see. I'm not seeing, okay, there we go. So nutrition and exercise were commonly used, but healthcare-directed counseling was not commonly used by these patients. So only 24% of patients who were using nutritional supplements were receiving any nutritional counseling, and only 10% were receiving formal exercise training or counseling. And despite the interest in nutrition and exercise, there was a really high prevalence of obesity in the MPN patients. And higher MPN SAF-TSS mean scores were noted in patients who were overweight in comparison to patients who had normal weight, suggesting that healthy body weight may modulate a symptom burden, and this was statistically significant. So the fatigue was also lower in patients who are participating in strength training and in aerobic activity. And fatigue is one of the most sort of vexing syndromes that patients have when they have myelofibrosis. And interestingly, exercise and aerobic activity seem to mitigate that. There were many, many supplements used by patients, but there was only one supplement that had a statistically significant impact on the MPN SAF-TSS score and the fatigue measurement score, and that was omega-3 fatty acid supplementation. And this begs the question of potentially looking at the role of omega-3 fatty acid supplementation in patients with MPNs, that it seems to mitigate symptoms. 80.2% of patients felt that their needs were not heard by their healthcare provider regarding the use of integrative therapies. So patients are not really discussing these therapies with their physicians, and this ends up in potentially are not being able to treat patients effectively. I think it also points to the fact that there is an unmet need in the treatment of patients with myelofibrosis to give them therapies that may mitigate their symptoms that are beyond the medications that we have to offer. There are other integrative studies. There is a study by the same author looking at an online yoga intervention where patients were given the opportunity to tune in to an online yoga course 2 or 3 times a week. And there were improvements in the TSS scores in pain, sleep, anxiety, and depression, and a decrease in the TNF alpha level at week 12. This is interesting because it shows that there is a possibility that interventions that are integrative may actually decrease cytokine burden in patients with myelofibrosis. And this is another area of study which I think would be incredibly important in this area. So physical activity may improve fatigue and depression and anxiety levels and sleep, as well as physical fitness in patients with hematologic malignancies. And there was a large meta-analysis actually looking at integrative medical interventions in all sorts of patients who have hematologic malignancies. And across the board, whether you had other malignancies such as MDS or MPNs, or even some chronic leukemias, that physical activity seemed to be the most important integrative intervention in improving fatigue, depression, anxiety, and sleep. These preliminary studies suggest a real value to integrative medicine in patients with MPNs, and further studies need to be done to investigate the roles of body weight, physical activity, massage, and nutritional supplements in the management of MPN symptoms, and the relationship potentially of these interventions to cytokine levels and other markers of inflammation. These sorts of studies are done looking at particular drugs. The imetelstat study, for example, that was presented at ASH, they were looking at the level of cytokines and how they changed with treatment of the drug and how they may have changed TSS scores. And this is important if there are other interventions which patients can take, which are beyond the drugs that we have to offer that will improve their outcome. We need to study these, I think, in more detail. And clearly, when 80% of patients feel that physicians do not hear them and their medications are insufficient to treat symptoms, more studies need to be done to evaluate lifestyle changes on patient outcome. Very interesting in the SIM study, that overweight patients seem to have a higher burden of symptoms than patients who were normal weight. So maybe that lifestyle changes, helping patients to lose weight and to be more physically fit, would actually improve their overall outcome and may improve some of the hallmarks of the disease, such as high cytokine levels, which cause potential progression of disease and worsening symptoms. My focus really is to introduce to you the idea of certain integrative strategies and how they may improve your outcome.
Ellen, this was excellent. So one of the questions I thought was very good is there any benefit to join a brand new study versus joining a trial that is in phase 3?
I think that the purpose of the different phases of trials are different. So a phase 1 trial, we're really looking at the safety of the drug. So when you join a phase 1 trial, we don't really know what the right dose is of the drug to give a patient, and we don't know what the toxicities are. So when you join a phase 1 trial, you're joining a trial of a brand new agent, then they're not really sure what the right dose is, and it's usually, you're in the early phase of experiment. So when you decide to join a phase 1 trial, you're making a decision that you want to be part of the early phase of developing this drug. A phase 2 trial is where we've already established what the toxicities of the drug are, and we've established really what the right dose would be to treat patients. And in a phase 2 trial, we're actually looking to see how efficacious is the drug. Now that we have a good dose and now that we know what the safety profile is, when we treat patients with the drug, how well is it working? So that's the purpose of a phase 2 trial. And phase 2 trials are done, really to determine whether the drug is going to work. And if there's a real strong signal that the drug is going to work, it goes to a phase 3 trial, which is the trial which is needed to get the drug approved by the FDA. And a phase 3 trial is usually the intervention drug versus the standard of care. So you're randomized. You don't get to choose, but you're randomized in the trial to either the treatment with the study drug or to treatment with the standard of care. And in that trial, they really carefully study whether what we're doing already is better or worse than the addition of the new drug. And this is what is needed to go to the FDA and to try and get the drug approved. So when you're joining a phase 3 trial, you're joining a drug trial where the drug has been established to be effective in a phase 2 trial. But you may not be randomized to the arm that has that particular drug. So sometimes these trials have what we call a crossover, where after 24 or after 50 weeks, If you're on the standard of care, they allow you to cross over to the study drug, but that's not always true. It depends on the particular trial. So when you're joining a trial, you have to realize what the point of that trial is and make a decision for yourself that you are comfortable joining this level of study. So, we are delighted that if you enroll on any of these types of trials, but we like you to be well informed as to what the purpose of the trial is, and for you to decide, whether you are comfortable being in a phase 1, phase 2, or phase 3 trial. I hope that answers your question.
I would think so. That was pretty thorough, and we hosted a program just about clinical trials a couple weeks ago, and hope that these patients, were able to see that. If not, it was recorded, and they can go back and look at that information, because it was kind of a clinical trials 101 to help them. But that was a very thorough answer. Dr. Ritchie, which omega-3 fatty acids were studied?
So patients just essentially evaluated or put in a survey that they were taking omega-3 fatty acids. So the brands, exactly what they took, that's not recorded. That's not there. So I can't really tell you. The only thing which is important is that patients actually reported taking over 100 supplements. Everything that you can imagine, actually, and that the only supplement that was reported that patients took that had any sort of impact on the total symptom score was omega-3 fatty acids. So given that data, it's interesting, right? So it may be worthwhile then studying omega-3 fatty acids, and if there is a relationship to total symptom score in a broader number of people, and whether there is any biological effect. So it's just a coincidence really on this study right now with some statistical significance, but it really just is, points to the way that it might be interesting to look at this in more detail. But it's also really important to look at that information and realize patients are deciding to take supplements really without counseling with any nutritional counselor of a very wide variety, and that it appears that there is no difference in their total symptom score if they happen to be taking the supplement or not. So I think that that's really the take-home message, that just because your aunt tells you that black cohosh might be an important supplement to treat your disease doesn't mean that that's an expert opinion or that it's going to change your total symptom score. And that if you're going to take supplements, you should probably have nutritional counseling where they recommend to you that you need a particular supplement in your diet.
I agree wholeheartedly. I'm not an expert, but I do agree because, and we also know that a lot of the supplements out there have not been looked at by anyone except the company that's manufacturing them. So there is no way to know.
The FDA does not control what is in your supplement.
That's right. And so
you buy a supplement and it says it's black cohosh, it could not be black. It may not be. It could be just crushed up Tums in there or something else.
Yeah, exactly.
You don't know what's there. So it's incredibly important to think very hard about taking supplements and making sure that you're doing it under the guidance of a physician or a nutritional counselor, and that there's an actual need for it.
Yeah, I agree wholeheartedly. I'm glad we talked about this because we do get that question a lot from patients saying, well, I'm taking this, or should I be taking this? And I say defer to your physician always. But here's another question for you, and then we'll put add Raajit to the conversation. My wife was recently diagnosed with MF. She is 35 years old, and I do want to interject right here that we are seeing younger and younger patients with myelofibrosis, but also with MPN, and that we do have a program coming up in Washington, D.C. if we can meet in person. If not, it will be online. And Ellen, you've participated in our Women in MPN program, which might be helpful for this young woman. She does not have any symptoms. Is there a time frame that she will notice these symptoms? And this is sad, but how many years does she have?
So without a lot more information, I'm not going to prognosticate as to how long
Yeah.
that she has, but I would like to, go back to something that Dr. Rampal said, which is that, perhaps we should be treating patients with myelofibrosis earlier. And this is particularly true in a young patient. And a young patient like this, we may think more strongly about transplantation, depending upon what kind of donor is available for this particular patient and what their disease looks like. I think that a young patient like this, we look at very differently, and we would want a careful evaluation of her bone marrow, of her genetics, what her NGS panel looks like, what sort of genes might be mutated, and what her chromosomes look like, and probably intervene to treat this patient earlier. But I would suggest that you bring your wife to have a consultation with an MPN expert, and hopefully one that has a lot of clinical trials which are available to treat patients. And that she may be a very good candidate for a clinical trial of some of these new drugs that may improve overall survival and may improve or prevent symptoms. And that would be really my primary recommendation I would have for this particular family.
And I can, if I can add, just having been around in this space for so long, that many patients live long lives and very productive lives. It's just very uniquely different for each patient.
Right.
At this point, I'm going to add Raajit. Are you there? There you are. Okay, so we have so many other questions for both of you, and I'll let each of you respond if you would like to piggyback on what the other person says. But what are my options if the 15 milligrams 2 times a day of Jakafi doesn't keep my spleen from enlarging? Are there other ways to shrink the spleen? Raajit, do you want to go first?
Yeah, I mean, I think that question sort of gets at something Ellen and I both talked about, which is that, unfortunately, over time, we see that people do fail. Let me rephrase that the correct way, which is that the Jakafi fails the patient. Let's not use the medical parlance, right? This is not an uncommon thing, but, are there standard of care things one can do? There are things that have been studied, using conventional medications, like we were talking about the hypomethylating agents. But I think the reality is that this is really when a clinical trial is warranted, right? When we've exhausted what's really FDA approved, then we need to start to think about, options that are biologically promising in the context of a clinical trial, assuming one wants to go on a clinical trial. But if one is not comfortable, then there are other things that can be thought about that have been studied. Conventional drugs, I mean.
Ellen, do you want to add anything?
I would agree with that. I will say, and I want to emphasize that, all the drugs that were talked about at ASH actually many of them were in patients who were ruxolitinib failures, and there were decreases in spleen volume in all of those studies. So it really does, I really emphasize that it is a great time to join a clinical trial, and particularly with drugs that we know are efficacious. And we have drugs going into phase 3 trials, so we really know that these drugs are promising. There are things that we can do, but the clinical trial, is really your opportunity to be introduced to the newest, probably, and the best drugs. We have other JAK2 inhibitors like fedratinib. We do have hypomethylating agents. There are things that we can try, and there is data, to support these things. But it's really an excellent time to think about joining a clinical trial.
And as you both said, it's remarkable how many there are, and we always praise those that are involved in clinical trials. It's quite a commitment, and we really appreciate anyone that's here today that has been in a trial or is currently in a trial, because it's so necessary. Raajit, I'm going to ask you this question first, since we have worked with Vietnam vets. This was the question we always get: is it probable that I got an MPN from my exposure to Agent Orange? And Raajit and I just spoke about this last night, because we've been working on this for quite some time. What do you want to add something to that question, or answer that question?
Yeah, I think my answer is sort of several-fold. One is that, can environmental exposures lead to MPN? I think the answer is yes, they can. I mean, we've known this from the data from the atomic bomb in Hiroshima. There was an increased myelofibrosis. There was also increased CML. We've known this from some Superfund sites around the country where there's been an association. Now, is there direct proof? There is not direct proof. Is there an association for environmental exposure? Yes, there is an association. With Agent Orange, it's a tricky thing, because I think the government is always they're asking for direct proof. But the problem is that there have been multiple cancers which they have deemed reasonably associated with exposure to Agent Orange. So it's very difficult to argue that this cancer is the exclusion, right? I think if we're saying that toxins can cause disease like myelofibrosis, and that Agent Orange has been linked to multiple things, including blood cancers like multiple myeloma, it's very difficult to then argue that this is somehow special and exclusionary. So I think that it is a reasonable conclusion.
We have hundreds in our database, hundreds of Vietnam vets that have an MPN. So it doesn't seem like it is just coincidental. So we have so many questions. So here is another one. Is there any research that integrates Eastern medicine practices to address MPNs, such as acupuncture? Ellen, do you want to take that?
Now, in the SIM study, acupuncture was reported, but in a really small number of patients. So that, there were not a lot of patients, and it did not show real differences in that small number of patients in total symptom score, or in fatigue scores, or in depression. Acupuncture is certainly, a popular integrative medicine strategy to control pain. And there is no study that's specifically looking at that in MPNs. As I said, it was a small number of patients who reported acupuncture as their intervention on the SIM study.
Raajit, do you have anything to add to that?
No, I think actually I learned from Ellen's talk today. I wasn't aware of that particular study, but I mean, it's such an important question, right? We talk, at least, I opened my talk talking about biology and mechanisms, but on the other hand, people are symptomatic with this disease, and the drugs that we have do this amount. There are plenty of patients who are symptomatic and not getting any benefit from pharmacologic agents. I just think this is a really important question.
And I remember when I was at the MPN Research Foundation, and Bob Rosen, the former the founder, who is now not with us, unfortunately, but he definitely used the practice of acupuncture for the neuropathy issues he had in his feet, and a couple other things, that were symptomatic from his PV at the time. But and it did help a little bit, but it wasn't great, I have to say, for him. It could be for others. Can either of you talk about the FibroMet study, the early results out of Brazil that is suggesting metformin has an anti-fibrotic effect? Metformin. Do you know about this? Anybody? Either of you? Ellen?
Well, metformin has been studied in hematologic malignancies, and there's some evidence that metformin may have some biologic effects on the stem cell that might be responsible for the development of certain hematologic malignancies. It's an incredibly interesting drug, metformin. It's approved to treat diabetes. Many early diabetics are on this drug, but there's no definitive evidence yet in any clinical trials looking at hematologic diseases that it's going to change outcome. That being said, it does interfere with the leukemic stem cell, and that there may be some sort of biologic effect, whether there's a clinical effect or there's an important effect in patients, we don't know. The study that you are referring to in particular, I am not familiar with. But I am familiar with, there's a basic scientist at Cornell who has been looking at the role of metformin and the leukemic stem cell, and there is activity. But what looks great in a test tube, doesn't always work when you put it into a human being. And what looks good in a mouse doesn't always work when you put it in a human being. So, I always take these studies as incredibly interesting, but until I see a clinical effect in a human being, I'm a little skeptical. And I think that you would need, a very rigorous type of study like the ones that we're talking about today. Those using, nabitoclax and the BET inhibitors. A really serious study to sort of take a look at the activity.
Raajit, do you have anything to add to that?
Yeah, I would agree with everything. There was data presented at ASH 2 years ago now, I think, looking at the effects of metformin, and there was a modest effect. But so many of the drugs we have pleiotropic effects. They affect a lot of different things. Does that mean that they're going to give you the effect that you desire at the doses that we use clinically? Not really, not necessarily. So I think it's interesting, but probably preliminary.
Okay, and this patient has been told that he or she has too many comorbidities to participate in a clinical trial. How is that determined?
So clinical trials have eligibility criteria. And the eligibility criteria and the exclusion criteria can be quite long, and it can be problematic for myelofibrosis patients. I don't know about Raajit, but certainly it's so frustrating to me that many patients are excluded because of their platelet count, that the platelet counts that are required for most of these clinical trials are much higher than the average MPN patient, so they are excluded on that basis. It also requires usually generally good organ function. Your kidneys have to be working, your liver has to be working. And they're often pretty stringent requirements around cardiac function, that your heartbeat has to be just right, not too long, not too short, and that you can't have had a serious cardiac event, in recent time, or another cancer that might be smoldering or not even important, but that you have at the same time. So if you are not qualified for one trial, sometimes you qualify for another trial because the eligibility criteria are different from one trial to another. So just because one trial doesn't work, another trial might. And some trials are more permissive, such as the pacritinib trial allows platelet counts of 25,000. So that allows us to put patients with lower platelet counts on that trial. Some trials are more permissive about, hepatic function and renal function. So it's different with each trial. Sometimes if you really have kidney failure, or you really have, or you have chronic hepatitis B, or you have, something like that, which is a serious comorbid problem, you may not qualify for clinical trial. But we can probably use other agents that we already have to try and treat you. And sometimes, if it's appropriate, we can ask for compassionate use of drugs. But that's under a special circumstance. One trial to be excluded doesn't mean you're going to be excluded from another. So looking at multiple clinical trials may be of use.
Raajit,
Yeah,
anything to add?
with that, the restrictions are there to protect the patient and to protect the trial. Because if a lot of people who are very sick end up on a trial and many of them don't do well, the question is, did they not do well because they were sick from something else or from the study? So I think there's, regardless of that, there's a lot of frustration because we end up in the situation a lot where a patient would be a perfect fit, but there's something that's quirky, their heart rhythm is too long or something. It's frustrating. But I think, as Ellen said, not every restriction is the same for every single trial. And even if we can't get somebody on a trial, we have conventional things that we can do. And sometimes when drugs are later in their development, companies are willing to release them under what's called an emergency use authorization, which is sort of how we're all getting the vaccine for COVID right now. So I think that is a mechanism. So there are other mechanisms.
Okay, and are either of you familiar with sculpting the spleen to reduce its size? Ellen? I've never heard of it.
I would be a little afraid of that, just knowing what the spleen looks like and what the spleen is composed of. The spleen is a very, very vascular organ. So, cutting into a spleen in any way would be something that would scare me, actually, because there would be a high risk of bleeding. And I think the only way that you could sculpt a spleen would be to cut the spleen, and that would be very, very concerning. And we often use radiation, to try and decrease spleen size, and we do that because we don't cut the spleen, but we are able to kill sort of a larger number of cells in the spleen, and by doing so, we're able to shrink the spleen, and we can do that more safely. So there's even procedures to remove the spleen called a splenectomy, and that's much safer per se than cutting into a spleen. So the idea of sculpting or cutting into a spleen would not be something that I would favor.
I've never heard of it. Raajit, have you heard of this?
Sculpting is for clay, not for spleens. Yeah, that would scare me as well.
So the next question, what are your thoughts, or what is the latest data or information about an MF patient taking aspirin every day? Raajit?
The data, with aspirin and myelofibrosis is not as robust as it is in PV, certainly, or even ET for that matter. And it becomes a little bit more tricky because patients more often than ET or PV have low platelets. So we come into this discussion a lot. I think the things that we can take away are that the JAK2 mutation, at least regardless of diagnosis, seems to increase the risk of cardiovascular thrombotic events, even in people who don't have a known malignancy. These are people who have something called clonal hematopoiesis. So I think there is some reasonable thought as to using a baby aspirin in somebody with a JAK2 mutant MF whose platelets are preserved. I think it's less robust in somebody with lower platelets or somebody with a calreticulin or MPL mutation. So it's more of a case-by-case basis, whereas with PV and ET, we're most often it's part of our standard of care.
Ellen, I know you've done a lot of work in cardiac health and MPN patients. What are your thoughts about?
I mean, I agree with Raajit. In general, a JAK2 mutation, you're at higher risk of a cardiovascular event, and that would be a reason to treat with aspirin, and as long as your platelet counts were robust enough to tolerate it. Otherwise, you look at the individual patient. If you have other cardiac risk factors, and you have family history, other things that would point to a concern, then that might be a reason, even in a calreticulin patient, to think about giving that patient aspirin. Or you're a diabetic and you happen to have, an MPN or other things that would give you a high risk. So I would say that the case for aspirin and MF, other than JAK2 positive patients, is really case by case. Looking at comorbidities of this patient, other medications the patient happens to be taking, how active the patient might be, and you know, looking at their overall cardiovascular risk. So each patient needs to be evaluated as an individual, I think, to make that decision.
Okay, and getting back to health and, you know, physical and dietary issues, does regular strenuous aerobic exercise help stimulate red blood cells and hemoglobin production in MF patients that are anemic, even if it somewhat increases their fatigue? Ellen?
I don't think that's actually known. Like a study looking at, you know, different degrees of aerobic exercise and its impact on the development of blood cells, or its impact on cytokine levels, or its impact on any of these things is not well known. I mean, the SIM study did show that aerobic activity actually, you know, improved patients' fatigue, but oddly, it decreased their quality of life. So, you know, it's really one of those things that's kind of a question. I think that that would be an outstanding study to do, to see what the impact of aerobic exercise is on the development of blood cells in general in regular people, but also, you know, looking at patients with MF. You know, the interesting thing about that STEM study is it's really just food for thought, right? You know, that it is interesting to sort of think of what the role of exercise might be in improving symptoms in patients with myelofibrosis. You know, I think how vigorous exercise needs to be, nobody knows. Like whether you run a marathon or whether you walk around the park once a day, you know, it may be the same. So we don't really know the results of any of the level of intensity and whether that would make a difference.
Dr. Rampal, I thought there was a study. I know there was a yoga study that was very positive, you know, in patients with MPNs, but I thought there was another one, you know, not vigorous exercise, but that exercise in general is always good, I would think, but like you're saying, it depends on the patient, depends on, because we always would say, even if you walk to the mailbox and back, you know, just doing something that's getting your blood moving would be good.
Right. I mean, I think, you know, look, one of the principles has to be that with regard to thrombotic risk, at least, right? Anything that increases your risk of having a heart attack increases your risk of a thrombosis in general, arterial thrombosis. So some activity better than none? No question. I think that's a common sense intervention. But I think, as Ellen is pointing out, how vigorous the activity is in terms of its relative benefit, completely unknown, right? As somebody who bikes 4 miles a day, you know, getting some stimulation of the red blood cells versus somebody who walks to the mailbox, I'm not sure I know. I'm not sure anybody knows that.
I mean, there are studies with cancer patients in general, and, you know, looking at sort of like breast cancer patients, for example, there are studies looking at the effect of exercise in breast cancer patients, where it looks like patients who are treated with chemotherapy for breast cancer who are active have a lower risk of relapse and potentially a better overall survival. So there are some solid tumor studies, but in MPNs in particular, they're not.
Yeah, that is interesting. That would be a great study. Okay, so we were talking about supplements, and there are two questions here. One is the efficacy of an iron supplement in managing anemia. Ellen, do you want to start?
In general, and I'm not in favor of iron supplementation in myelofibrosis patients. Many of these patients become transfusion dependent or require transfusion, and that will be giving you lots of supplemental iron. The problem with iron is when you have too much iron, it's really hard to get rid of too much. You know, that too much iron has a lot of health, some very poor health outcomes, and that you can't get rid of too much iron easily. And the drugs we have to try and help you get rid of iron have toxicities of their own, which make it difficult to give patients. So in general, I am not in favor of giving regular iron supplementation to myelofibrosis patients. Are there particular circumstances? A myelofibrosis patient who has a large GI bleed, for example, or something like that, then maybe I would think iron supplementation may play a role, but that would be for specific circumstances.
I've heard that over the years as well, not to. Dr. Rampal?
Not empirically, no, but I think, there's one cautionary thing to, I think, be told here, right? Is that if a patient has anemia and myelofibrosis, and they are found to be iron deficient, one of the principles is we have to figure out why, because just because someone has myelofibrosis doesn't mean they can't have other things. Recently I saw a patient who developed this exact scenario, turned out to have colon cancer. Ruben Mace has told the same story. So I think that I agree with Ellen. Empiric iron is not something I would recommend, but if someone is iron deficient, it may have a use, but the first question is, why are they iron deficient?
Exactly. All right, so does MF affect the spine in any way? I have many problems, this is the patient speaking, and pain in my lumbar sacral backbone, and am unable to sit for longer than 10 minutes without pain. Could MF be related to this? Dr. Ritchie?
MF can cause bony pain, so it's possible. As also, when you have a large spleen and potentially a large liver, and you have that extra abdominal weight, that actually affects your spine and it affects your posture, and it can cause you to have back pain. It's not also, it was also highly likely that, you can have other causes of back pain as you grow older. You develop degenerative disc disease and other things, which can be exacerbated by having an enlarged spleen or by having a little bony or muscular pain from myelofibrosis. Like we were discussing, with iron deficiency anemia, if you have a lot of back pain, it's important to investigate that there are not other causes of that particular problem. You need to talk to your doctor about what's happening and, have an appropriate workup for that particular problem. Maybe you have slip discs that are pressing on nerves or other things, or, other problems that need to be addressed.
Raajit, do you have anything to add to that?
No, I 100% agree with that. Common things occur commonly, and just because it occurs in somebody who has myelofibrosis doesn't mean that common causes can't be what's going on.
What tests should I be having done as I age with my MF diagnosis? I have a CBC MP drawn every other month. I was told that I have the JAK2G mutation, but on blood work done 7 years ago, discovered I did not have the JAK2G mutation. So is there anything else this patient should be tested for or be doing? Dr. Ritchie?
So I have one patient who's a little bit like that, who is JAK2 positive, became JAK2 negative, and then became JAK2 positive again. And it all depends really. The tests look for different levels of positivity of JAK2. So it depends sometimes where the test was drawn, what the sensitivity of the test is when you had it. So JAK2 can sort of potentially, you could be positive and negative. I like to get what I call a quantitative JAK2 when I can, which tells me exactly how much JAK2 the patient has, and that can be helpful. As you age, we're looking, you may or may not have a regular doctor who's following your blood work. I find that many of my myelofibrosis patients have decided that I am their primary care doctor, so that that depends really on what sort of blood tests that might be ordered. In general, when I'm following my myelofibrosis patients, particularly if I have them on medication, I'm following their CBC, I'm following their organ function with looking at their kidney function and their liver function. I will occasionally look at their LDH, which is a marker of cell proliferation. And I don't always draw a JAK2 and see where they are. Periodically, you know, I may draw a quantitative JAK2 to see where they are. If you are depending upon your myelofibrosis doctor to be your primary care doctor, you need to tell your doctor that that's what you are doing. In that case, there are other tests that, you know, I may do that are mimic more what your primary care doctor would do. And I'm looking more particularly at your cardiac health, potentially your thyroid, your vitamin D levels, other things. I prefer not to be the primary care doctor for my patients, but it's important that you have someone who is following all of those parameters.
Dr. Rampal?
Yeah, I would agree with the same principles. You know, typically I got CBC and organ function, typically liver, kidneys, and LDH a couple of times a year. I don't tend to follow the genetics more than once a year, you know, once every couple of years, depending on the clinical scenario.
Are there any newer studies about prednisone with MPN patients, with MF especially? This patient has been taking prednisone for 3 years, and it has improved their hemoglobin from 8 to 11. And they have also had secondary myelofibrosis for 14 years, and they take 2 baby aspirin daily. Dr. Rampal? So the study of prednisone.
Prednisone, well, people have historically used steroids and sometimes in patients who have anemia and myelofibrosis. We don't use it empirically much. There can be other causes of anemia, though. Sometimes people have what's called an autoimmune hemolytic anemia that can respond really well to prednisone, even at low doses. So it depends on what the cause of the anemia is, but the use of prednisone empirically for myelofibrosis, really not much of a role.
And I'd like to add that prednisone is not a benign medication, and that prednisone is a highly immunosuppressive medication. And if a patient is getting benefit from prednisone, you know, we like often to switch them to some other medication to address their anemia so they're not on prednisone for a long period of time. Prednisone has so many effects in the body, it's really remarkable that the one tablet can do so many things. But, you know, it increases your risk of diabetes, it can increase hypertension, it can increase your risk of all kinds of infections. So being on prednisone for a long period of time is something that we try not to do. If a patient gets benefit from prednisone, we'd like to see, is there some other medication that we could use that might be less toxic than prednisone over time?
So one big question that we get all the time is patients that are dealing with the skin itching and the unbearable, you know, trying to live with the skin itching, taking cold showers, cool showers. After all these years, is there anything out there now that can help MPN patients, particularly with MF at this, you know, for this event? That you could suggest? Dr. Rampal, can you suggest some?
It's a very difficult thing, right? What I will say is, in my experience, the JAK inhibitors have been the best drugs for this by and far. I think, you know, people with terrible itching with ruxolitinib many times respond beautifully. You could try other things empirically, antihistamines, antidepressants sometimes, and other asthma type drugs, but they don't, in my experience, they work in a very small number of patients. So I think the JAK inhibitors are honestly the best drugs for this.
Dr. Ritchie, would you agree?
I hands down agree with that. You know, I think that for pruritus, that ruxolitinib is a fabulous drug. And even if patients are not really candidates for ruxolitinib in other ways, if they have unbearable itching, you know, that's a reason that I would use the drug in almost any MPN, because it's a terrible, terrible symptom, and ruxolitinib works beautifully for this most of the time. Everything else that's out there is really temporizing and only works in a small number of people. So The asthma drugs, the antihistamines, they have side effects and they work really in just a small number of people. So, I really highly recommend, even if it's not clinically indicated in other ways, if there's severe itching, that ruxolitinib is a drug to try.
This patient has been on Jakafi for 4 to 5 years, but now their counts are rising again. Is there a problem, and what should they be discussing with their physician? Dr. Ritchie?
Well, it may be that the dose of Jakafi needs to be adjusted. So, it's important to know sort of what dose the patient's on, and maybe the dose needs to be changed. If ruxolitinib is not working, then it's important, if their counts are rising, I would probably do a bone marrow biopsy at that point in time and sort of see where we are. Is there something happening in the bone marrow that I need to know about? Are there new mutations in the bone marrow that may be there? And looking at that information, deciding potentially what the next best step is. There are clinical trials open, for patients, for example, who have IDH mutations, that there may be a clinical trial open where we can use a drug that targets that, plus ruxolitinib potentially. And there are many other clinical trials that are probably better or worse for different types of situations that are potentially open for that patient. So if they're starting to proliferate or there are changes in their disease, that's really an indication for a bone marrow biopsy and to really understand what's happening and what the next best step would be.
Dr. Rampal, do you want to add anything to that?
Completely agree. I think, whenever there's a change, either in the patient's symptoms or the spleen or their blood counts, you have to ask why. And doing a bone marrow and reassessing the disease is the first principle.
Okay, good advice. The patient is 16 months post bone marrow transplant for myelofibrosis 3. I had he or she had a JAK2 mutation plus 2 other mutations. Have you seen cases where MF comes back by itself after a few years, or have you seen cases where it comes back in the form of a leukemia instead of MF? So with a bone marrow transplanted or stem cell transplant patient, have you seen the disease come back, and is it worse? Is it the same? Dr. Rampal?
Yes, I mean, I've seen it, and that's the literature says this does happen, right? Does it happen in the majority of patients? No, but I've certainly seen people relapse with myelofibrosis and occasionally relapse with leukemia who went into transplant with myelofibrosis, but that doesn't mean it's going to happen.
Ellen?
Yes, I have seen people relapse, and it's a risk that we discuss with patients before they go to transplant, that there is a risk of relapse, and there is a risk you can relapse with acute leukemia. I have seen that before. This does not happen in everyone. So if this patient is in remission, I don't want them sitting around worrying, that they're going to relapse their disease or relapse an acute leukemia. We discussed this, and I'm sure the transplants are discussed it with this patient before it happens, that this is something that can happen. But the purpose of the transplant and all of the treatment after the transplant is to try and prevent that from happening. And we really hope that the graft versus the myelofibrosis effect will really take hold and will allow that patient to remain in remission.
This is a question that we actually get quite a bit, but perhaps your insight would be very useful here, and that is for patients that want to participate in a trial. We talk to a lot of people about the challenges that our patients have that want to be in a trial but possibly can't leave work, don't have daycare, don't have the money to participate. And this question is, what if it isn't in my area, but I would like to participate? We do know patients that fly to different, across country actually, to participate in trials. How do you deal with the patient that wants to be in a trial but is coming from a long distance, or, can you speak to that? Dr. Ritchie, do you want to go first?
Well, actually, I think this is one good outcome from the COVID pandemic, that in the past, clinical trials were very not hospitable to, for example, telemedicine, or to having labs done in a facility that is not a central facility, or even in allowing us to ship drugs to a patient. We were unable to do that. But COVID has changed that a little bit. Patients who were already on clinical trial, we did not want to strand them during the COVID pandemic. So we were able to use telemedicine, we were able to use local labs, and we were able to send drug. I think that from far away, it's possible to enroll on a clinical trial. You will have to visit the center that has the clinical trial available, at least for screening and for your initial treatment, and at various intervals during the clinical trial. But we can probably do it with less pain and suffering than had been done in the past because of the advent of telemedicine and the more flexible feeling of the clinical trial sort of facilities in allowing us to treat patients from far away. I hope actually that this is a small revolution, just as there's a revolution in the number of drugs which are available to treat myelofibrosis, that we're having a little revolution in the way that clinical trials can be conducted, that maybe we can reach more people in more rural places by using technology. So I'm hoping that that's here to stay.
I agree with you wholeheartedly, and I would think the patient population would agree as well. We have, as you said, telemedicine, but also sending the drug to their homes and giving them instructions on how to use it. I mean, it's just been phenomenal. And, so Raajit, do you have anything to add to this?
Yeah, I agree. I think, the telemedicine has had some positive impacts, and I think, we were forced in the height of the pandemic to convert patients who were on trials into telemedicine visits, and it worked, and it was, for the most part okay, and that's taught us something. So I think that's going to be, one way that this hopefully works better. I think the other thing that a lot of us have tried to impress upon the pharmaceutical companies is engaging some of the major, private practice groups around the country. I mean, a lot of oncology care is delivered not in academic centers, and there are some really, very large private oncology groups around the country, right? Getting trials into the hands of those folks is absolutely essential, because they're going to be able to reach more people than we ever can.
Okay. This is a follow-up to the prednisone question. If we can go back to that real quickly. Is there something else that this patient could be taking to deal with the anemia that is not as toxic? Also, could the prednisone be affecting my white blood cell count, but I have no infections? Ellen, do you want to speak to that?
Yes, it could affect your white blood cell count, because one effect of prednisone is demarginalization of neutrophils, that those cells that usually hang out just on the edge of your blood vessels and start to circulate in the blood. So you can see a higher white count. It all depends on the cause of your anemia as to what the right treatment might be for your anemia. So a deeper dive into what the reason is for your anemia. Do you have an autoimmune hemolytic anemia, for example? If you have an autoimmune hemolytic anemia, there are certain other agents besides prednisone that we can entertain to help treat your disease. Do you have a deficiency? Do you have a severe iron deficiency that we don't really know about, or something like that? Is it from your myelofibrosis? If it's from your myelofibrosis, we might want to use one of the other agents that we have, danazol, for example, or something else, to try and treat your anemia. So it's really important to have sort of a deep dive into what we think the cause of your anemia is, and then deciding based on that what the next best drug would be.
Raajit, do you have anything to add to that?
100% agree.
This individual has recently been getting facial rashes with Jakafi. Any recommendations from either of you, Dr. Rampal?
I mean, rashes can happen. It's not that common, but that's something that warrants investigation. It could be any number of things. It could, just be it could be a fungal infection. It could be potentially a viral infection. It could just be irritation from the drug itself. The underlying cause needs to be investigated.
Dr. Ritchie, anything?
I agree with that. Remember, Jakafi is an immunosuppressive medication. So we always worry that you could have a rash that has another cause, like an infectious cause. It could be that it's just a drug-related rash, but I would probably send you to a dermatologist for further evaluation, because rash is not something that we see so often in patients with ruxolitinib. And when we do see it, we get worried that something else is going on.
Getting back to the aspirin and vitamin C, is there any research that suggests taking vitamin C and selenium and aspirin helping to delay the symptoms and need for a transplant? Dr. Ritchie, do you want to respond to that?
As I have said, there's, in the SIM study, no supplements sort of changed, overall symptom score. So it probably is not delaying, any effects of the disease. Those specific combinations, there is no clinical trial looking at that specific combination and whether it delays, the development of myelofibrosis. And I think you have to be really careful about using supplements. And there's so much anecdotal data, and there's so much advertisement and data on social media. It's really incredible. You buy a multivitamin on Amazon, and all of a sudden you're seeing ads for 50 supplements or commercials or info commercials for different supplements that are coming up on your feed. So it's really, really important to sort of get some nutritional counseling before you take supplements. And there is no study looking at sort of specific, combinations of supplements and how they may delay any malignancy.
So given the time frame, what I'd like to do now is ask each of you to, first of all, answer the question about COVID, and then just give a brief summary of your opinion of what drugs are looking very promising right now for the year 2021, because my understanding is there are probably 2 that might be approved by the FDA, possibly this year. And just give me your thoughts on going forward with MPNs and the landscape, what the landscape looks like to you. But first, very quickly, I think I know the answer to this myself, but for our audience, do you recommend getting the vaccine, the COVID vaccine? And should our patients be looking at Pfizer versus Moderna versus Johnson & Johnson? I mean, what is if you could answer that question. Raajit, do you want to go first?
Yeah, I think let me frame the response in this. With regards to COVID and myelofibrosis, we don't know a lot. What we do know is there is at least one study from Italy. They were obviously very hard, and they have a number of MPN patients. Patients with myelofibrosis, particularly when they were taken off of their JAK inhibitor, had really not great outcomes with COVID. So not getting COVID for patients with MF is important. With regards to the vaccines, do we know anything about their efficacy in myelofibrosis patients? We don't. There's no granularity of data. But at the end of the day, the data that has been published with regards to Pfizer and Moderna, the vaccines are incredibly efficacious, and there really isn't any signal from the patients that have been studied thus far in the clinical trials that there is an inherent danger signal with those vaccines. And now, millions of people have received the vaccine. The patients have brought to my attention things they're worried about that they've heard in the news media. But at this point, there is really nothing that has emerged as a cautionary signal So I would absolutely recommend that patients get vaccinated, and I will be completely honest, I've been vaccinated. I'm making sure my family's getting vaccinated because I believe in the safety of the vaccines. So I would absolutely advocate for it.
And Dr. Ritchie?
I agree completely. I absolutely advocate for the vaccine. Not getting COVID as a myelofibrosis patient is incredibly important versus getting COVID. And we have an easy prevention, which is vaccination. I don't know how well myelofibrosis patients are going to respond to vaccination, but in the case they respond even a little, it would be positive. There is no difference between the Pfizer and the Moderna vaccine. They're both highly efficacious. I am welcoming the addition of the Johnson & Johnson vaccine so that we will have a bigger supply and it will be easier to vaccinate more people. I've been vaccinated. I was fine. I have vaccinated my entire family. They're fine. My mother, my father, who are much older than me, are fine. Everyone has done well with the vaccine. You read in the newspaper or online about something that happened. It's like the doctor in Florida whose platelets went down. Everyone knows about this doctor. There are case reports of this happening. But if you look at the millions of vaccines which have been given, the possibility that this could happen to you is 0.00001%. So that's so small. So I would concentrate on the fact that these vaccines are going to get us out of this pandemic situation, and we'll be back to leading more normal lives. And I recommend it for everyone.
I mean, I couldn't agree with you more, both of you. And every one of our specialists has said the exact same thing. And the ones that have seen patients that have had the vaccines, so they are perfectly fine. There's nothing going on. It's great. I will age myself by saying I've had the vaccine and I'm very happy I did. And I was great. I feel great, no problem. And so, you know, I'm not an MPN patient, but very safe, very effective, I believe. And so with that, in closing, what I mentioned earlier, if you can give us your view of the landscape in the next year or so, Ellen, if you would start and just wrap it up.
So I'm very excited that we're going to hopefully have some new drugs as part of our armamentarium. I've participated in the BET inhibitor trial. It's going to phase 3 trial. I think that Dr. Rampal mentioned that trial to you. I'm hoping that we have a positive outcome and that drug will be available for us. It appears at this point in time to benefit patients, and I'm excited for that addition. There are other drugs in phase 3 trials. You know, the navitoclax, which is the BCL-XL inhibitor, is going to have a phase 3 trial, and that's another drug which may come to fruition and be available to us. Momelotinib, which is the JAK2 inhibitor that also seems to improve anemia, you know, also looks like it's something that can join the armamentarium. So I'm excited for the development of these new drugs. There are other drugs in the pipeline which are really, really interesting. Imetelstat, you know, there were hints in the presentation at ASH that it did improve overall survival. And that's another drug which I believe is going to phase 3 trial, and, you know, will be interesting to look at those results. So I think that, you know, this is the golden age, or this is like the most promising period, that we have an embarrassment of riches almost of new drugs in comparison to when we started. And not only, I think this is going to be revolutionary for our myelofibrosis patients, that we're going to have many more drugs with which to treat their diseases, and perhaps soon, you know, in 2022 or so, depending on what happens with this pandemic and how the FDA sort of paces their approvals.
Raajit?
You know, I think, as I said before, and I think as Ellen has said, this is an amazing. There are so many drugs that are in late stage clinical trials, which means there is a promising signal there. And you know, I've been an investigator on a number of these trials, and I don't want that to sort of get in the way of the message, meaning that I don't want to come across as biased for one or the other drug. So I don't think that, you know, there's any one particular drug that's the be all end all. I think they're all showing some really promising signals. You know, I think that one of the challenges that will emerge if we're fortunate to even get a couple of approvals is how do you use them? Which patients are they right for? Is one drug right for a particular type of patient? Can you sequence them and use a combination in a patient up front, and then if they're not doing so well, switch to another one? These are going to keep us busy for a number of years. First, we have to get there and get these drugs approved. But you know, the situation when I sit down with a patient today in February of 2021, let me just be blunt, is drastically different than when I first met a patient with myelofibrosis in 2013. It's an amazing thing.
Well, I would agree. And, you know, we've all kind of been around for a long time in this space. And I just think it's remarkable. I cannot thank you both enough. I know that taking the 2 hours out of your day is tremendous. And we just absolutely so much appreciate your work and appreciate you being with us today. And to the patients out there that still have questions, you can email those to me and I will send them off to these lovely people. And they're usually really wonderful about responding right away, actually. And you know, again, we're sorry about some of the technical issues, but that is just the way it goes these days. And I hope that all of you benefited from these excellent presenters. And these are definitely folks in the trenches day after day after day in the MPN space. So thank you both very, very much, and stay safe. And we'll see you again soon, I hope.
Thank you, Anne, for including us. I really enjoyed it.
Likewise.
Thank you. Thank you both. Okay. And thanks to our sponsors, if we could show those. We would not be able to do these programs without all of our sponsors. They've been fantastic. And, you know, keep watching for these new treatment options. They will be coming right along soon, I'm sure, or within the next few years. And again, we have to thank our industry partners. They've been great. Have a great day and be safe.